Good evening, everyone. I'm Dr. Bhagya. I'm presently working in Velachery, Dr. Agarwals, and I've completed my fellowship in medical retina and uvea in Arvind Eye Hospital, worked in Arvind Eye Hospital in Tirunelveli. And retina is something which I'm really passionate about, and I thank Dr. Agarwal's clinical board for giving me this wonderful opportunity to moderate. Hereby, it is my honor to introduce our esteemed speaker for today's webinar, Dr. Sunil Ganekal, sir, who has done his MS, DNB, FRCS, and is also a clinical head of Davangri Netralaya, which is also a unit of Dr. Agarwal's Eye Hospital. Sir has his Vitreoretinal Fellowship from Shankar Netralaya and also Ocular Oncology Fellowship from New York Eye and Ear Infirmary. Sir is an active research association with the Mayo Clinic in United States of America. Sir was also a past chairman in Scientific Committee Karnataka Ophthalmic Society, editor-in-chief in Karnataka State Journal, and has published more than 50 publications in prestigious journals such as BMC, BJO, AJO, and JAPOS and JCRS. And thank you for taking your time to present today, sir. Thank you so much. And hereby, it is also my pleasure to introduce our distinguished panelist today, who is Dr. Kumar Saurabh, sir, who is currently working in Kolkata, Dr. Agarwal's Eye Clinic in Salt Lake. Sir is an extensive experience consultant who is associated chair of R&D committee of Dr. Agarwal's group of hospital. And sir has graduated from Bhagwan Medical College of Hospital, and also has finished his MS residency in RIU, Kolkata. And he holds his Vitreoretinal Fellowship in Shankar Netralaya, where he was awarded Best Outgoing Clinical VR Fellow. And sir was practicing, had practiced in Shankar Netralaya, Kolkata, has published over 130 papers, and which was also awarded with Honor Award for peer review in Indian Journal of Ophthalmology, and also served as editorial board editor and thank you so much for participating today, sir.
Thank you for the kind introduction. Let me discuss the most important topic today. There is a macular edema and retinal vein occlusions. What are the challenges we face and how to tackle this or handle this problem associated with retinal vein occlusions. The retinal vein occlusions are associated with vision loss due to many complications, and macular edema being one of the significant complications which is associated with both the branch retinal vein occlusion as well as central retinal vein occlusion. So main complications in retinal vein occlusion could be in the macula. There could be increase in macular thickness due to the fluid accumulation or sometimes the exudation from the vasculature. The fluid accumulation either could be in the form of an extracellular or an intracellular accumulation. So it causes the loss of vision, preferably moderate to severe loss of vision can be seen. Similar to diabetic macular edema, the macular edema in retinal vein occlusions could be either in the form of a edematous maculopathy or causing an ischemia, causing an enlargement of the foveal avascular zone, or sometimes there could be a tractional component leading to something which is known as tractional maculopathy. What it is relevant to know about each one of is to basically to explain the prognosis to the patient as well as to the management aspect, whether to manage the patient medically or surgically or to tell the patient what is the cause for vision loss. One need to demarcate or classify these things according to the types of maculopathy. So if you look into the pathogenesis of macular edema in retinal vein occlusion, basically there will be retinal capillary damage. So whenever there is a capillary damage, there will be a release of both inflammatory markers, which in the form of cytokines, as well as vascular endothelial growth factors. The commonest inflammatory markers or cytokines one tend to see is interleukin 6, interleukin 8, the monocyte chemotactic factor, tumor necrosis factor, and the intercellular adhesion molecule. These are some of the inflammatory markers which gets released in retinal vein occlusion, and along with that VEGF. Both these, what they does is that causes the breakdown of the blood-retinal barrier, which increases the vascular permeability and leakage, which in turn leads to the macular edema. This is the pathogenesis of macular edema, how the edema develops in a patient with a retinal vein occlusion. When you see a patient with a retinal vein occlusion with a macular edema, you need to investigate. You should know the main investigation modality nowadays. The non-invasive modality commonly we tend to use is the OCT. Without OCT, we cannot practice nowadays the retinal, especially if there is a macular pathology. One need to do an optical coherence tomography as a examination has to be done. Fluorescent angiography only is relevant when you're suspecting a neovascularization or when you're suspecting a macular ischemia. Definitely FFA has got a role. The Opta definitely helps in detecting the neovascularization as well as the ischemic changes and the peripheral neovascular, the peripheral avascular areas, all these things. But the segmentation errors can occur if you're using an optical coherence tomography, Opta angiography in macular edema associated with retinal vein. Why one should investigate these patients is basically one is to come to a diagnosis whether the macular edema is present or not. Then staging can be done. How severe is the macular edema? Is there any traction component associated with that and other things and all? And the treatment. What is the pre-treatment and the post-treatment response? Whether the patient is responding to the treatment which you are given, how early or how frequently one should follow up the patients. So basically, to assess the treatment response, one need to investigate the patient with a macular edema associated with retinal vein occlusions. When you investigate a patient, especially with an optical coherence tomography, we need to look at certain biomarkers. Biomarkers are the indicators which shows that helps in assessing the prognosis or a treatment response. We need to look at one is we tend to look at the central foveal thickness or a central retinal thickness, which is a very relevant thing. Then other thing which you would like to look for is an intraretinal fluid accumulation or a cystoid fluid accumulation, which we tend to see. Then there could be a subretinal fluid in the form of subfoveal detachments. The other thing is the commonest thing which is very, very relevant with respect to the vision is the something known as drill. What is drill? This is a disorganized retinal inner layers. Basically, in the central 1 millimeter of the macular section, if you tend to see disorganization of retinal inner layers, it could then look for the vitreomacular adhesions or tractional abnormalities, whether the traction is due to the leakage or due to the tractional component is there or not, which helps us to make a decision whether to treat medically or surgically. Then you should look for something known as hyperreflective dots or hyperreflective foci, which helps to assess whether the macular edema is associated with an inflammatory or a non-inflammatory cause. Most often, inflammatory causes are associated with these hyperreflective foci. Most of them they should be differentiated from hard exudates. So these are uniform, tiny, which can be seen in the intraretinally. Sometimes subretinally also these hyperreflective foci can be seen. Apart from this, you can see a retinal thickening, thinning, or disruption of both the outer and inner retinal layers can be seen. So looking at these biomarkers, you will have a rough idea what could be the cause and how to go about with the treatment response and assessing the prognosis. I was talking about the drill. As the duration of macular edema progresses, even the not only central 1 millimeter, the outside the cells will also you tend to see a drill. So it is a progressive phenomenon. So it causes the poor visual acuity in a patient with a macular edema with a central retinal vein occlusion. What are the morphological types of edema one tend to see in a retinal vein occlusion, especially as a patients with BRVO? It could be a diffuse thickening, or it could be a focal thickening with fluid accumulation, or as I told before, there could be a serous detachment along with the macular edema. These are some of the 2-3 types of morphological changes one tend to see in a patient with a macular edema associated with a vein occlusion. In a CRVOs, definitely OCT can give a clue whether it's an ischemic or non-ischemic, looking at the thickening areas and hyporeflective areas and other things, which gives a clue. Apart from the FFA, which clearly says whether it is an ischemic or non-ischemic, vision, the FFA, OCT, all these helps you to glue to whether it is a ischemic or a non-ischemic thing, which helps you to follow up the patient, help tell the prognosis to the patient, and all these things can be explained better if you know the type of central retinal vein occlusion. So, what are the things one should look for if you see a macular edema patient with associated retinal occlusion? The most important thing is best corrected visual acuity at a baseline, which has got a largest impact on the visual acuity outcome. So, one should know what is the baseline visual acuity in these patients. The fluid definitely has got a predictive value which increases the accuracy apart from the vision. Other thing is look for a vitreomacular adhesions. So if the patient has got a vitreomacular adhesion, those tends to do better than those without the vitreomacular adhesion. Despite even though you tend to see a similar number of retreatments in both the groups, those who have got a vitreomacular adhesions tends to do better than those without. Obviously, the other thing one should know is the focal ischemia or atrophia, but in a long run may not be associated with the worse visual acuity. Unlike ischemia, if it is a gross ischemia, yes, but focal ischemia and atrophy may not contribute for such a gross loss of vision. When you compare a diabetic macular edema and AMD, the photoreceptor alterations which occurs in these patients with macular edema tends to cause a severe vision loss. But in a macular retinal vein occlusion associated macular edema, photoreceptor alterations do not seem to play such a significant role, unlike in a DME, that is diabetic macular edema, or AMD. The other important thing, as I told about the OCTA, that is the use of OCT angiography. One tend to look at the FAZ enlargement, that is a macular ischemia, is associated with worse visual-acutic outcome after anti-VEGF therapy, just because sometimes an anti-VEGF thing can increase the ischemic process, and higher mean number of macular edema recurrences are seen in this patient. If you see the pre-treatment, if somebody is seen with FAZ enlargement or a foveal avascular zone enlargement, one should be very careful and explain to the patient that you may have a more recurrences of the macular edema and the poor prognosis post anti-VEGF injection. So apart from that, one should look at on a OCT whether the outer retinal structures and as well as the inner retinal structures. Patients with damage to the outer retinal structures at baseline definitely benefits more from an anti-VEGF treatment than those with the inner retinal structures. Those who have got a more of an inner retinal damage at baseline, they improved the least when compared to those who are associated with the outer retinal structural damage. Another thing is as I told before, the two important mediators which causes the macular edema, one is the cytokines, inflammatory cytokines, other is the VEGF. So because the thing in DME associated thing, the cytokine concentration both are different and sometimes may differ from. So DME macular edema may not be as comparable to that of a vein occlusion macular edema. So one could be an inflammatory component could be associated more. In other thing where VEGF component is there, ischemic result insert would have caused the MAPE lens. In a BRVO associated macular edema, ischemia plays a more role than the cytokine. So as we call diabetic macular edema is more of an inflammatory disease. Even the diabetic retinopathy also is an inflammatory disease because the inflammatory components are released more when compared to the other vein occlusions where ischemic changes occurs more due to the VEGF. The other thing is the VEGF and IL-6 levels which can give a prognosis in this macular edema. The level of IL-6 in vitreous cavity is significantly higher in DME when compared to the vein occlusion. So it shows that inflammatory biomarkers are more in DME when compared to the vein occlusions. Inhibition of VEGF may act both with what is the mechanism by which the VEGF causes an edema is by one is by inflammatory thing, other is by angiogenic process. Both these components, so anti-VEGF prevents both these things as well as the vascular leakage as well as the release of acting on the VEGF, so it reduces the macular edema. So there is a strong correlation between if you do an FFA in these patients with vein occlusions, there is a strong correlation between the concentration of VEGF and the severity of the non-perfusion. So for example, if you can see in a mild non-perfusion, the concentration level may be more. In a VEGF concentration increases if the non-perfusion is severe. So if one has got an access to the assessment of VEGF levels, it can definitely quantify them and tell the severity of the thing, which helps you to make to explain to the patient the prognosis. So if you got an access to the assessment of VEGF, one should do it. So what are the prognostic factors? The first I told as before, the one should look at the presenting visual acuity, the duration of retinal vein occlusion, which is very, very critical, especially if you're dealing with an ischemic CRVOs and other things. One should look into the inflammatory or a non-inflammatory cause because you may have to add steroids if there is an inflammatory component, atherosclerotic causes and other things. And also one should know the probable etiological cause, whether it is an inflammatory or non-inflammatory. Other thing is know whether it is an edematous maculopathy or a tractional maculopathy. Assess the degree of ischemia by octa. The most important thing is when you look at the macular edema, look at the 2-3 things, whether it is a rebound macular edema, refractory macular edema and recurrent macular edema. These are very, very critical terms. Rebound means once it has responded and it has come back again. Refractory, you are given a multiple injection, in spite of it has not responded at all. Recurrences can happen anytime due to many of the reasons which I will be telling in down the next slides. What are the causes for the recurrent macular edema and retinal vein occlusion? When to treat and when not to treat? This is a very, very critical question when you see a patient with a macular edema with retinal vein occlusion. Why? Because sometimes the patient may lose follow-up and 1/3 of the patients may spontaneously improve. We may say that whether to treat or not. 1/3 may stay the same, 1/3 may get worse. So you can't take patients for granted. So whether the whom will respond and whom will have spontaneous resolution. But definitely, if you look at the patients who are treated with anti-VEGF and those who are observed for the natural course of resolution of macular edema, the best corrected visual acuity and the central foveal thickness were better achieved in a patients who were treated than those who are allowed for a natural course of recovery of macular edema. So what are the treatment options available for a macular edema associated with retinal vein occlusion? The lasers, definitely what we used to use, the green lasers, or nowadays we tend to use a subthreshold lasers for the treatment of macular edema. Intravitreal injections, definitely either in the form of anti-VEGF or steroids. Nowadays we can use a suprachoroidal steroid injections also. Of course, if you've got a tractional component or associated epiretinal membrane along with the macular edema, one may have to resort to the vitrectomy. So, what is the role of laser? Do we have to really laser the macular edema in a patient with the vein occlusion? In a branch retinal vein occlusion, looking at the visual acuity, somebody who has got a less than 612 visual acuity can be considered for a focal laser. But laser was popular until the anti-VEGF came into the existence. Once the anti-VEGF era started, probably we stopped using much of the lasers because we tend to get a better visual acuity or a better morphological improvement with the anti-VEGF than the lasers. Sometimes you can do a combination treatment. You can combine anti-VEGF with a rescue laser to bring about an improvement. The another thing one should read is studies have shown also that ranibizumab treated patient or an anti-VEGF treated patients almost does better than a laser therapy. So I always feel laser should be kept as only as a rescue treatment or a second line of treatment rather than the first modality of treatment for the macular edema associated with retinal vein occlusion. Even the retained study has shown that the grid laser photocoagulation did not significantly alter the visual outcome. So one should keep laser as a second option rather than the primary treatment modality. Nowadays, definitely subthreshold macular laser reduce the complications associated with the conventional laser like associated scotomas and other things and all. Better outcomes and 1 year studies when combined with anti-VEGF, for example, in this patient, 6 weeks post third anti-VEGF injection, this is still the persistent of macular edema. Approximately 5 months post the subthreshold laser, you can see very well the edema is resolved and so is responded to the subthreshold laser. So subthreshold laser definitely has got a role if you can combine that with this, relevant cases of an anti-VEGF or a refractory cases of anti-VEGF. One can add the subthreshold. Intravitreal injections. So commonly we know that the most commonly used drugs are either bevacizumab, ranibizumab, and aflibercept. Of course, the age-old triamcinolone acetonide has been tried, and the steroids in the form of steroid implants. The newer drugs could be in the form of Pegenex, that is the faricimab. Okay. The what we should look of what is the when you call it there is a resolution of macular edema post anti-VEGF is when there is an absence of either intraretinal fluid or subretinal fluid in the macula for at least 6 months after the last injection. Then you can say that. So one need to closely follow up these patients for at least 4 to 6 months before you say that you have successfully treated the patient, because especially in patients with a CRVO, rebound macular edemas are quite common after 4th month or 5th month. So one need to closely follow them for at least 4 to 6 months to say that the patient is doing well and has responded to. Most of the drugs are FDA approved except for the bevacizumab. Sometimes we can combine two anti-VEGFs together in this patient. For example, the Avastin, bevacizumab, and ranibizumab as a combined treatment has been given, which gives a response because sometimes it may be refractory to one drug and responds to the other drug. This is a very, very important case where it shows that, see, for example, the macular edema, the brolucizumab has been given. You can see beautifully the first 3 months, there is the reduction of macular edema. If at this stage, if you lose the patient on a 4th month, if the patient is lost to follow-up, it comes with a late rebound macular edema in CRVO at 16 weeks. So what is the relevance is don't lose the patient. Even the macular edema is resolved. Tell them that you need a serial follow-up because the rebound or macular edemas are quite common, especially in the central retinal vein occlusion where the ischemic insult is more. So tends to have you need to have a sequential follow-up at least for 4 to 6 months to tell the patient that you are safe now. So another thing is the Vosudex definitely, especially in pseudophakic patients and other patients, those who are not steroid responders, non-glaucomatous patients, in these patients, definitely, and especially patients with a central vein occlusion macular edema, you can consider a Vosudex or a dexamethasone implant, which gives a very good response at 2 months and progression. The drug can act up to 4 months to 6 months, and you can get a good results in these patients. So let me bring about some of the studies. These are age-old studies which gave conclusions in a BRVO, like BRVO study, that is a BVOS. It is a age-old study which has been done for the relevance of studying the laser photocoagulation in a patient with a branch retinal vein occlusion. They taken a 612 as a criteria. Then the bevacizumab being used, which is shown to be effective in treatment with macular edema. SCORE trial, basically they highlighted the relevance of IVTA in patients with, but one should be very careful with the cataractus changes, glaucoma in these patients when you're using an IVTA. The other thing is a Bravo study which studied the 2 doses of ranibizumab, which responded very well with the ranibizumab. And the Geneva trial, where DEX implantation patients had a significant improvement in best corrected visual acuity and no significant difference or no significant glaucomatous changes of the rise in IOP was seen. And another study is a Vibrant study where the aflibercept was studied and significantly greater benefit was noted both on reduction in CRT and macular edema was noted post aflibercept treatment. So these are some of the studies which gives us a guidelines of when to use a laser, when to which anti-VEGF to be used, and what are the things when to use steroids and all, which I'll be discussing further also. Similarly, there are many standard studies which have been tried, like central retinal vein occlusion study, which clearly shown that there is no role for a prophylactic PRP or there is no role for a grid laser. The SCORE trial, similar to BRVO, IVTA has been tried. Geneva trial, DEX implant has been tried. CRUISE trial showed the relevance of ranibizumab, showed a rapid improvement in visual acuity as a resolution of macular edema. Copernicus and Galileo study basically study the aflibercept. They showed that the vision improves with aflibercept and the reduction in central retinal thickness was noted. Even the bevacizumab shows a very good response. So these are some of the studies which shows that the modalities of treatment one can plan and what are the conclusions and how these studies can be implemented into day-to-day clinical practice. There's another recent study where which considers the faricimab, and you can see that faricimab responds very well to the macular edema secondary to retinal vein occlusion. But I don't have a personal experience with this drug. But it's a recently introduced drug, can be considered in refractory cases. Cost is an issue with this drug. Another clinical trials relate study the 2 doses of ranibizumab. With a higher dose of ranibizumab also there was not much difference. So conventional dose is more than enough rather than doing an high dose of ranibizumab. So in a Marvel study, they compared ranibizumab with versus the bevacizumab in macular edema. But even though the ranibizumab did better, but there was no statistically significant difference between a ranibizumab and bevacizumab in macular edema associated with. Now coming on to the anti-VEGF, we need to look into the anti-VEGF, which one to choose, dose to be given, how often to be given, and these are the to be followed. So RVO remains a chronic by nature. So it carries a very high treatment burden. You need to repeat it sometimes 4 months, 6 months, so up to 4 years. The anti-VEGF needs to be followed up in one way or the other. So either you can give anti-VEGF in the fixed dose regimen, or a Prorineta or a PRN regimen, or a treat and extend. I'll explain one by one what is it exactly. In a fixed dose regimen, what we do is, in a SHORE study, it has shown that we give a fixed monthly injection or as and when required based on the response to treatment. Despite the slightly higher percentage of macular edema reduction in the PRN treatment group than the monthly group, the PRN group showed a significant larger best corrected visual acuity improvement over the monthly group. So one need to, if you look at the cost effectiveness, probably PRN is a better thing than a fixed monthly. Sometimes it can cause a treatment burden to the patient. Recurrence of edema after stabilization does not. So one thing to be very important thing one should note here is the patient is stabilized. If there is a recurrence of macular edema, no need to panic. But because we need to closely follow up this patient based on not only on the rebound of the macular edema, the vision and many things have to be taken into criteria, at least for up to 1.5 years. So no need to panic if there is a sudden recurrence of edema or after stabilization. Probably we have to plan it accordingly. Treat and extend. What is this treat and extend? The treat and extended regimen differs in a retinal vein occlusion when compared to the AMD or age-related macular edema. What here is, in a extended treatment, you extend the treatment by 2 weeks interval. If there is a reduction of macular edema up until 3 months, and then discontinue therapy thereafter if there is no edema, unless there is a recurrent edema, at which point we resume the monthly injections again. So you need to treat it and extend the duration of treatment. How this strategy differs from that of an AMD or an age-related macular degeneration is, in a treat and extend protocol for AMD, in which we reduce the interval by 2 weeks or so, rather than going back to the monthly injection. Here we go back to the monthly injections. Probably we may not go back any AMD patients. So in a retinal, especially CRVO patient, we may not stick to the monthly injection. Sometimes there are some patients I have given 2 weekly, 3 weekly injections in a patients with a CRVO, because sometimes the edema, rebound macular edema can occur, or the response may be suboptimal. In these cases, one may have to resort to a shorter duration of interval of treatment rather than a monthly treatment. So long-term treatment data support is required, because you follow up the period for at least 1 year with subsequent extension upon functional and anatomical stability. You need to look at not only at the anatomical stability, functional stability, both has to be taken into criteria. One thing one should remember is anti-VEGF is not the gold standard answer for all macular edema associated with retinal vein occlusion, because there could be an inflammatory component. So if you stick to only the anti-VEGF, sometimes you may get a suboptimal response. So you may have to combine steroids, or you may switch over to steroids. So one should keep that in mind rather than sticking into anti-VEGF alone in treating a macular edema patients. I was talking to you about what is known as recurrent or a rebound macular edema. Why this occurs? The proposed theories are 2-3 theories which have been told. One is the upregulation of VEGF receptors, which could be the first causes. The tachyphylaxis. The other thing is anti-VEGF sometimes negatively influences the vascular perfusion in some of the cases, so which can cause a recurrent or rebound macular edema. The natural course of recurrent macular edema is worse than that of eyes treated with intravitreal injections. So these are some of the theories which have been explained why the rebound or a recurrent macular edema occurs. Almost 78% of the patients with retinal vein occlusions to have a recurrent macular edema, more so in a CRVO group than compared to the BRVO group. CRVO, BRVO, almost 60% of the patients may have a rebound macular edema, and some of the studies have almost shown up to 99 to 100% patients may have a rebound macular edema. So these patients needs to be closely followed up. Mean time for recurrence is quite earlier in CRVO. It's approximately 1.2 months than in a BRVO. So CRVOs tends to recur, macular edema tend to recur much faster when compared to the BRVO. Mean period for macular edema resorption also quite slow for CRVO. It's around 3 to 4 months when compared to the BRVO, which is around 2 to 3 months. So the recurrences occurred sooner and more prominent in CRVO patients. So CRVO macular edema patients are more troublesome than when compared to the BRVO patients. So implants can be considered as a rescue therapy in cases with if there is an anti-VEGF failure, or as I told before, if anti-VEGF is contraindicated, if somebody has got a pregnancy or a recent cardiovascular events, in such patients, pseudophakic patients, one can consider a DEX implant patients, and steroid is definitely a role. The other thing could be suprachoroidal injections. Suprachoroidal injections, triamcinolone can be given 3.5 to 5 mm from the limbus, approximately 4 mm from the limbus. You can inject into the suprachoroidal space and can get the resolution of the macular edema. The IOP spikes are and other things are less when compared to the intravitreal triamcinolone. There is another study which shows the relevance of suprachoroidal injections with the treatment of macular edema. They have seen a very good response with the suprachoroidal steroidal injections. You can combine the suprachoroidal injections along with the anti-VEGF treatment. Like in this case, you can look at over a period of time, aflibercept was combined with an suprachoroidal injections. 80% of subjects have got a resolution of macular edema with a combined modality of treatment. Apart from this, certain topical things can also work. You can use a difluprednate or steroids in some cases, non-steroidal drugs for the macular edema resolution. Even the diamox have been used if there is a serous exudation or a macular elevation or a serous detachment. Or brimonidine can be tried in some patients with a edema, with the macular edema associated with retinal vein occlusions. So these are some of the alternative options one should consider. One should not think the alternative things. If there is a contraindication to intravitreal injections, you can try out these things. Another important thing is inflammatory markers. I've been discussed all these inflammatory markers, how they increase the macular edema. So if they are increased, probably one should think more in lines of steroids than the anti-VEGF. So I consider three markers. One is the VEGF, other is IL-6, other is the IL-8. If the VEGF levels are high, there is no second thought. It has to be anti-VEGF monotherapy. If IL-6 are high, it indicates there is an inflammatory component. Stick to steroids. If lower levels of all three cytokines are there, VEGF is low, IL-8 is low, then go. If you see all three are increased, that means IL-6, IL-8 and VEGF, then shift over to the anti-VEGF. So central foveal thick can be considered as a rough treatment apart from the visions, when to stop the treatment and do a monthly follow-ups accordingly. There is a chart which clearly shows the relevance of three markers which I showed, VEGF, IL-6 and IL-8, and when to observe, when to go with anti-VEGF and when to go with the steroids. The other thing which can be considered in a refractory cases is the what is known as targeted retinal photocoagulation, or what we call TRP, similar to PRP, where we tend to do a peripheral vascular leakage, what is known as PVL. You identify by ultrawide field angiography which are the areas of peripheral vascular leakage. You to these patients, some patients who are refractory to anti-VEGF treatment and all these have in mind, or you may get rid of it repeating the injection regularly. As I told before, you keep an option of all the drugs. Sometimes you may have to shift over to systemic steroids, carbonic anhydrase inhibitors, NSAIDs. So you should think an alternative apart from the anti-VEGF. As I told again, the rescue laser, especially anti-VEGF, can be combined with the rescue laser. You can sometimes do a direct laser photocoagulation to the leakage areas if there is a refractory macular edema. That also causes the resolution of macular edema. So in BR, consider if there is a treat. Triumph can work intravitreally as supra. The cannot afford dose parameters alone. Main things to be considered is poor baseline associated macular edema. Important poor prognostications with a BR. In a CRV, ischemic changes, the laser has got a limit. You can consider, as I told before, refractory case, consider rescue or switching the drug from one anti-VEGF to another. The most important thing is DRBF patients are very troublesome. One should frequent injections, monitor probably may up months to a year in a patient's CRVO. So CR macular edema needs a special macular edema. So I'd like to conclude that for a macular edema associated retinal vein occlusion. Combination and sequential treatment should be an option. Duration of action, but be associated with side effects. Therapy, especially subthreshold laser, you can with anti-VEGF. Better visual results in edema, young, lower best corrected at baseline. So many parameters should be in treating rather. Thank you.
Sir, thank you so much. Actually, macular edema secondary to retinal vein occlusion is a very exhaustive topic, but still you made it very intriguing.